My name is Pedro Moreno. I'll be your moderator today. I'm an interventional cardiologist and a professor of medicine. We have a fantastic case. We love to hear from you. So please send us all your questions. You can do it on the website or in YouTube. And remember, all these cases are recorded and available at www.ccclivecases.org. I'm going to lead the case now from Dr. Sharma and his associate directly from the cath lab.
All right, Pedro, good morning, and sorry for a few minutes late, but we are all ready for another educational session for our structure live case. We actually now will be presenting a case who has a mitral valve degeneration and will have a transcatheter mitral valve replacement, TMVR. So our crew and team is the same, myself, then Dr. Keeney, our structural health system director, interventional, then Sahil Khera, Director of Structural Intervention at Mount Sinai, and Dr. Gilbert Tang. He is the surgical director for the structural heart interventions for the health system. And then we have our fellow Manish and Negar. We had three structural fellows, and rest of the team. We have Dr. Larakas is on the echocardiography, and Dr. Moi Trin is on the anesthesia, will keeping patient very cool, calm, and collected. And the rest of the staff, usual faces you see. With that note, we are ready to start our case number 50 of our structural, supported by, shown here, with Edward Life Sciences. And these are our individual faculty involved and their disclosures as shown. And this is the case number 50, 85-year-old male with the history of shortness of breath and CHF exacerbation. Patient had 2 surgeries, the valve replacement and CABG, and has done fine. And now he started having increasing heart failure symptoms and was admitted. The echo basically showed degenerated mitral valve bioprosthesis with flail leaflet, mixed moderate MS and severe MR with systolic flow reversal in the pulmonary vein flow pattern. Mean mitral valve gradient is 7. No evidence of LA thrombus. Now patient has been on warfarin and ejection fraction is about 40%. So this is actually the TE which was obtained earlier with a degenerated mitral valve, but we can show the live echo. If we can change it to the live echo by Dr. Stem Larakas, and he can comment on it. The pictures looks very good, which were done a few weeks ago, and now we are ready for today. Yeah, this is today's thing.
Yes, good morning. On my left is Yov, our structural imaging fellow. As you can see, in the middle of the mitral bioprosthesis, the LV function is looks borderline about 50%. The right ventricle is mildly decreased function, mild to moderate tricuspid regurgitation. As you can see here, the PA pressure is about 55 by the echo Doppler imaging. The aortic valve is mildly thickened leaflets with minimal AI, no AS. And this is the prosthetic mitral valve. As you can see, very degenerated, thickened leaflets, flail leaflet, severe, actually torrential mitral regurgitation. This is the bicommissural view. This is the 3D zoom image. As you can see, the leaflet is of the bioprosthesis is flail. You can see the sutures of the mitral prosthesis. This is with color. All the mitral regurgitation is central from transvalvular. No PVL is seen. This is a true view, or another view of the mitral prosthesis. Wow. Again, the severe valvular mitral regurgitation. This is a glass image of the mitral valve. And again, severe transvalvular mitral regurgitation. Mean gradient, as Dr. Sharma saying, 9 millimeters mercury. So degenerated, severely degenerated mitral bioprosthesis, mostly mitral regurgitation, some MS. Most of this gradient is most likely from the torrential mitral regurgitation. Dr. Sharma, back to you.
Beautiful. Well, beautiful images, right? It looks like from some cartoon. Many of those 3D or 4Ds. But anyway, this is clearly, as we shown about, in terms of MR with some inflow gradient, and now CTA. I'll ask Gilbert to comment on?
Yeah, so if you look at the internal diameter display at 27 Hancock 2, it's actually the internal diameter is on 22, 23. So yeah, and the aorta mitral angle is quite favorable. You can see huge left ventricle, so no issue LVOT obstruction. Next slide. So you can see some of the views in terms of potential fluoroscopic. We will show that here live shortly. Next slide. But here's the thing. So you can see that the Hancock valve is actually a very friendly valve for mitral valve and valve because you only have a 3 dots. That's the outflow of the commissures where the commissures are mounted, surgical valve mounted, but also the ring. So you can see the ring at the annulus. Now the downside of that, this valve is not fracturable. So if you have a small valve, you cannot expand this valve further. And you can see that this is a true ID of 22 millimeter. Next slide. So you can see how this might be placed with the SAPIEN 3 valve. You want to kind of make sure that you're not too close to the ventricular side because you want to be flaring out a little bit more on the ventricular side, but also because we're oversized a little bit, you want to optimize that in terms of the gradient. But you can see the valve in valve has a 23 versus 26. We're debating that, but because this is mostly MR, not MS, we're going to go upsize to a 26. And also the 26 is a taller frame. So when you do mitral valve in valve, you don't want to risk embolization, right? So the taller frame will actually help you in this particular case, but you obviously need to be concerned about residual gradient under expansion.
So therefore, initially we were thinking do a 23 plus 2 cc's extra or just go with a 26.
Right. So
now,
if it's stenosis, we probably would go with 23 plus 2 because the thickened leaflets may limit the expansion, and so you have better anchor and better expansion of the valve. But with the mostly MR situation that the stamps show, I would say 26 would be a safer choice here.
Okay. So we have changed the plan. So what we announced versus now, that's okay. Because this is still about 25 versus 26. So we are 26 is good. So this is what we are going to use now, 26. And Anu will talk about, we have made some slides about this, how to use the valve-in-valve SAPIEN for the transeptal approach. And the equipment, Anu, you want to comment on any of those?
Yeah, so how to do the transeptal, I think we can go briefly. Stam?
Yes.
Okay, show the TE. So of course we have a TE guided as well as a fluoroscopy guided. So it's going to show you as we are coming down. You can see we use the needle and you can see it coming down and then go to the next view. But more important, I think we can see is fluoroscopy. If you can show us the fluoroscopy again.
Can we show floor and echo together, please?
Thank you.
Floor and echo together, if you can.
So this is where I think you need a combination of both echo as well as fluoroscopy. So I think the teaching point here is you have the surgical valve. So you draw a line in the center, the perpendicular, and you have to be below, which you can see that it's below, and then posterior, exactly where we want it. And this is about one full SAPIEN valve length. If you put a SAPIEN valve at the surgical valve at the superior portion, one SAPIEN valve length, you are away from that. So that's about the right height. So you can get a beautiful trajectory. If you do a transeptal here, your trajectory will be very good. So we will be able to get the valve through the septum into the surgical valve. So I think this explains very well. So we did the transeptal, and once you do so before doing the transeptal, give some heparin, even though the INR, today the INR is about 1.9. And once you've done the transeptal, we have a pigtail there, and you can see the hemodynamics right now. Can we show the hemos?
Active hemodynamics, please.
So it's a large V wave, very little gradient across the mitral valve. We have a pigtail in the LV just for the hemodynamic purposes. You don't really otherwise need it, but otherwise we just got the hemodynamics here because many times it could be mixed and have a MS plus MR, but here looks more of an MR, maybe some gradient about 5 or 6.
Yeah, about 7. Yeah, that's the same way it was there before. Okay, let's go to the slides now. Coming back to go to the previous. Let me go back to previous slide. Yeah. So these are the what we have done.
Through the
equipment. I'm saying just we have for our purpose, because a lot of people ask how to do various steps, so we have put it together. in terms of equipment, as you can see, transeptal needle, your standard catheter, multi-purpose, and radio frequency energy. Although now we have the newer device also you are testing. Sahil, what is the new transeptal
Safe
device?
Cross.
It's called Safe Cross. It's a new device, has a balloon-tipped catheter for safe transeptal. So it's not a dilator needle system. It's a balloon-tipped catheter and relatively easy to use. But
And
we're
then-
still learning from
Yep, and then you have all these wires, Confida, Safari, and non-compliant balloon for balloon dilatation, and steerable transeptal catheter. So
This is the Agilis, yeah.
Agilis is the one which we use most of the time, correct?
Yes.
And then in the end, you might use the ASD occluder if it need to be. So these are again step by step, basically heparin, transeptal puncture, full heparinization, crossing the mitral valve, the pre-shaped stiff wire, and balloon atrial septostomy. You have to dilate the balloon, E-sheath from femoral vein with the stiff wire, commander insertion, sapien deployment, and hemodynamics. So those are just put it together, and the femoral vein closure. Sahil, you want to say that how you do what you use for closure of the vein?
one per close, and then if need be, we put a mattress sutures. It's relatively atraumatic closure for the most part. Yeah.
And artery, just a short arterial puncture is only 5 French.
5
so,
French,
right?
so you can manual it or use one of the closure devices.
So these are the steps which already Dr. Keeney has pointed out. This is what we wanted to show, the line drawn, and that's where you're doing balloon, the transeptal puncture. We have not done any balloon yet.
Not
right?
yet.
Yeah. So we are just with the transeptal at present, and the whole idea is that we have put all these things together. Ideal puncture location is that it has to be coaxial for the valve advancement. And balloon, always you need to do sizes wise they recommend 10, 12, or 14 based on the size of the sapien valve you are going to use. And also we added that advance the inflated balloon, and we just want to go through this very quickly. This is make sure it's the valve is correctly mounted, because now it is compared to what we do for the tower procedure. So after all that, these are again final steps which we have put it together, and we'll go actual right now, and we are just to put purpose there was to put everything together in this case presentation of our live case. All right, Anu, you are ready now. We are.
Yeah,
okay,
so
let's
we
go back
have,
to active
if we
fluoro.
can have things ready, if you go back to fluoro, and no need for hemo, just go back to the fluoro, and then I think
take
show
the
our
pigtail
hands,
out if
right?
need be from
So we have the pigtail, if you can see there, yeah, we have the pigtail, which is in the left atrium. Yeah, so right now the next step is we are going with the Confida wire.
Okay, you have one pigtail in the ventricle, one pigtail in the atrium.
Yeah. Now, actually, you know what? We could remove the pigtail
Yes.
from the ventricle and use it for. Hold on. Put it back in the yeah. So will we just go to 200 scale for the blood pressure? So the step is when we are actually doing the transeptal,
Fluoro, okay.
we just have a
The
8
wire.
French sheath. And once we finish the transeptal, we already changed to Edwards E sheath on the Confida wire. Then we left with the pigtail. So now we are back with the Confida wire, and now
Dilator.
first. Dilate. Septum.
Yeah.
So now we are going with the Agilis.
Same steps every time.
And which wire is in the left atrium now?
It's a
We
Confida.
have a Confida.
Confida wire in the left atrium, now going with the Agilis sheath.
Yeah. Should be able to deliver easily. Good. Okay, you're across.
Yeah, it's okay.
So now,
Okay, we have
Now
a
put
Gillis
the wire
across
back.
now.
Now give me the
so now give me a
multi-purpose. So now you have the Agilis sheath. You are seeing it from the camera.
flash the sheet, please.
Good. Let's flush the sheath. We'll go with the multi-purpose, easier to navigate the mitral valve.
Fluoro.
Give me a J wire, right?
Yep, and let's mag out now and mag in and show. Let's go to the implant view as well.
So
Okay,
as
good.
you deliver it closer, I'm going to take the wire out. Keep going again, a little more. Multi's not there, a little more. Good. Yeah. All right. Give me a
So
crossing
I'm
wire.
going to,
You can use J wire or crossing wire here because predominantly MR.
no. This J wire.
J wire, please. Thank you.
So relatively steep RAO angle for the
As you cross the
deployment view.
Take some flex off. Yeah. Maybe Stam can show us on 3D now.
Tell you what?
Never mind.
Yeah,
Yeah,
no,
but
I'm
too
through.
far down.
Yeah.
No.
So we are in the LV.
We're
So
crossed.
Confida, right? Give me some wet 4x4.
Wet 4x4s and give me the
Sure.
config again.
So this is the important step. Now your multi-purpose has gone all with the way to the LV apex.
Yep.
Now you're going to put a wire out,
Yep.
and things may just push back, right? That's
Yep. That's exactly right.
It should be okay. It's a very good trajectory if you see.
Yep.
That's where the transeptal helps in these cases.
Some ectopy more.
Yeah.
Good. Very nice.
Very nice trajectory there.
Okay.
Balloon, please. And now
Ideally,
you
we
can.
should
This
have.
is confida, right?
You want to leave it like that, or go with the long pigtail and change it?
No, this is good. That was good. Yeah, that's perfect.
okay.
Okay.
What size balloon you are using?
12.
14,
14? Okay.
14?
12,
12.
12. Let's do 12.
12 to
14
14, they
you-
say only for 29.
29.
Yes.
Yeah. Yeah.
So now I'm going to straighten the agilis.
That's right.
Wait,
Let me come there.
Okay, you come this way.
Yeah. You got it?
Yeah.
Okay, good. Hold the wire. You have the wire? So this is for the balloon septotomy.
No.
Hold,
actually,
hold,
the
hold,
wire.
hold the wire.
I'm holding the wire. He's ballooning the septum now. There's no
Okay, hold the
exchange.
wire.
Good.
What is-
Stan, we got balloon the septum.
Yeah, okay.
So Dr. Kinney, for predominantly MR, would you still balloon the valve or you only do it
No,
for
that
MS
that
cases?
is just to show us
Okay.
how the valve will traverse.
Okay,
That's
The
important.
balloon
okay?
should be across the
Hold the
septum now.
agilis.
Yeah.
It's just like a test for us. Okay, now we
When
are
you
across.
connect it,
Yeah.
can you connect it, please?
Yeah, good. Yeah, you can. Is the balloon across?
I think so. Looks okay.
Okay, go.
You can start going up
Maybe-
and then see if there's a waste.
Good.
Maybe
Go
if
up.
you advance a little more or not? The
No.
balloon.
Let's see. You see the waist?
You see
Yeah, we
the
see the
waist.
balloon. See the balloon, yeah.
Okay. A little bit more.
Okay, down, down, down.
Yeah.
Oh yeah, nice.
Yeah. It was not fully there, so
Yeah.
as you go,
Okay.
you're
Good.
going to
Okay,
go
good.
few more
Go up now.
millimeter, and yeah.
Okay,
Good.
go up.
Perfect.
Huh?
Mhm.
You see the waist?
Push
right?
it.
Do one more, do one more.
Now
Yes.
we're
Down.
talking, yeah.
Now we're talking. Yeah.
Yes.
Go.
All the way,
break
all the
it,
way,
break
all
it,
the way.
break it.
Wow. Very.
Oh,
It's a
Nice.
Now,
Good.
Cine.
okay, down. Okay, leave
One
it
thing
there.
to make a note for these procedures: if your patient had a mitral valve replacement,
I'm going inside.
yeah, through a transeptal approach, you definitely need to balloon because remember the septum will be quite scarred, so it'll be very non-compliant
go
in
up
terms
here.
of
This is something we do. Okay, good.
Also
What is
gives
the
us-
actual purpose of this?
Good.
And you
Yeah.
can emphasize what is the
Okay,
purpose
down.
of this dilatation, knowing that there
Down,
was
down.
down.
It's small. It's just we are creating the track for this valve to go easily.
Yeah,
right. So
yeah,
means it's
exactly.
basically forming the kind of curvature of the wire
Yeah.
where your valve is going to traverse.
So
So
now
that's it.
what I like to do also is the deflated balloon, you keep it, I'm going to advance.
Okay.
That will also tell me how the valve will behave.
I think
Okay.
defining the
See that we
trajectory
have a
is very
little bit
important.
Yep.
problem we may have, but I think overall should be okay.
Yeah.
Okay,
Okay, we can walk it out.
good. I'm coming out.
Yeah.
Good. So when we're coming out, we'll also have to take the agilis
Balloon
out.
out first.
Yeah, balloon out
Balloon
first,
out first.
and then the agilis will come off.
But the sheath is still in the left atrium.
Yeah.
Manu?
No. The sheath is no.
Is now in the right atrium.
Yeah, right
Yeah,
atrium.
no,
yes.
probably, yeah, in the right or maybe at the
Junction of
junction
IVC
of the IVC and right, yeah. Coming out,
Okay.
good.
Let me know when you have
Good.
wire.
Yeah, I'm not done yet.
Mm,
Okay.
I'm running out of
Now,
wire.
yeah, good.
I'm
I
running
have
out
the
of wire.
wire. I
You have
the
wire?
wire, yes.
Wire, come back now. Remember, you had to have that trajectory which you had earlier. Yeah, this is it.
Yeah.
Okay,
Okay,
now
Agilis.
we'll take the Agilis out. So I've undone the curve and Agilis is coming out and I will
Some
do that.
ectopy, Moy.
We need the balloon ready now.
Okay, valve.
Valve
ready.
is crimped.
Valve. not
We are
balloon.
going with a 26 millimeter.
Got control.
Okay,
Yeah,
now
wire,
you
right?
have the wire.
You have wire? Okay. 1 second, 1 second. Nagar, excuse me. Okay, good.
So we will align
Okay,
the
check
valve.
check orientation.
Yeah.
Okay,
Can we show
The
this?
skirt is atrial.
Yeah,
Okay,
just doing it,
atrial. Very important. Integrate.
Can you
showing
go
that? Can you see that?
focus? Bring the camera. No, it's like this. This camera.
Oh.
Yeah.
Yep.
Leave it here.
Okay.
Bring the camera
Yep.
down.
Very good. We see.
Are
Okay.
you able to see it? The skirt.
Yeah.
Yep.
Okay. You can actually sew it on fluoro as well, but this is probably more important because you can't really take the valve out afterwards. So
And I want to do little AP, no? When we're going up.
no, no.
Can I? Huh?
Oh yeah, you can.
Yeah.
You can. That's fine. We can do that.
When we go up.
Yeah, we can do it. But we have to do the.
Okay.
This is the final deployment.
This is all right.
Okay.
This is all
Watch the
right.
wire. Okay. Hold on. Okay, I have wire. Okay, the E system is down.
Confirmed.
Yeah,
Right?
confirmed.
Looks good. Okay.
Compared
good.
to E is up in the tower, here E is down.
Because we have to
Yeah.
turn to the right side of the screen.
Yeah.
So you go
Okay,
slow
wire,
here.
wire.
Yep. Yep.
The whole thing is a wire now.
Yeah, I'm holding the wire.
Careful. We may have to
Go
pull
slow.
the sheath back
He
a little
will.
bit.
He will. Yeah.
Yeah.
1 second. Let me mac out first.
You see that, Pedro? We are going to pull the sheath
Yeah.
back
second.
out so
So
we can
go
align
down.
the valve. Yeah. Sometimes.
Who sutured the sheath? No,
This
see.
one.
No, it's not
Good.
sutured.
Okay. 1 second, AK.
Good. Okay,
All right,
exposed.
looks good.
Okay,
Very good.
exposed, yeah.
Okay.
Okay, so now we're
So
gonna
we're
mount.
doing our usual things of aligning the valve.
Fluoro.
Okay, you advance the wire.
Yep.
I'm going to pull the balloon back.
Mhm.
Keep pulling back. Keep pulling back.
Mhm.
Keep pulling back. Yeah. Lock again.
And what about the ACT?
Rich.
You have to pull back more.
ACT is 330.
330, good.
Wonderful.
Good. Beautiful.
Looks very
Now
good.
then. Okay.
Okay, you happy with the
Yes,
balloon
I'm
position?
going-
You have
yes,
to pull
pull it
by a
closer.
little bit more, no?
Uh,
1 millimeter back?
Yeah.
You have to pull
You're
back 1
okay.
millimeter, no?
No, we're okay.
Okay.
Keep going.
Yeah.
So I'll need a little rail here from the
Yep.
third person.
Yep.
Trajectory looks very good. Delivery is
Look
good.
at that. Look at it. Okay, so let me forward save that, please.
Yeah.
Okay,
I'm
so let's
going to-
review. Okay, let me mac in now. Let's go to the angle.
Exposing the valve now.
Okay.
Okay. Advance the wire.
1 second. Let me get it ready to go. Okay, go. Yeah.
We're exposing the valve.
Yeah. You
Good.
have to hold
Unflex
it.
a little bit,
Who
yeah.
wants to hold? Who's
I'm
going up and who's
unflexing.
holding?
Good. Yes. Good. Good. Yeah, yeah. Looks very good.
You want to advance a little
Yeah,
bit?
that's-
Yeah,
Trajectory.
that's
Will
looks.
be once
I
we
think
pay
this is the way we have trajectory will be
Yeah.
okay, right?
Ask the echo.
Yes.
You are
The TE.
medial.
Yeah. Can we see TE also in
Yeah.
one side? Actually,
A little bit
you can
ventricular.
remove the hemodynamic, show the echo now.
Start more atrial. Start
Yeah.
more
Yeah.
atrial.
and very slow inflation.
Yeah.
Good.
Micro.
You're good, you think?
Let's test pace first. Test
Okay,
pace.
180.
This looks
We'll
good.
do some 3D here.
It came back.
Okay.
And maybe a cine or no
Yeah,
cine?
yeah, we are
We'll
going
do
to
it
do
off.
it.
Good.
Okay,
Off, off,
off,
This is good. This is good.
This is good.
Inflow to outflow to
Okay.
outflow. Okay.
right? Good.
Yeah, yeah.
Do some 3D.
Okay, 180. I'm going to go slow inflation.
3D. No, 3D zoom.
Okay, going up.
No, check it.
Very slow inflation. Beautiful. All the way.
Yeah. Very nice.
Very nice.
Very nice. Very nice.
Excellent.
Do we have to do a second inflation? Or
First
come
off.
up? Okay, off, pacer. We decide, do you need to do
Yeah.
a second inflation?
Actually, pace at 80.
I think we can do second inflation, right? Or no?
No, I don't think we need to. No, it's oversized. It's fine.
We've got a nice flare.
Okay, show us echo and give us some measurements because the balloon is across. You want to take it out?
No, you need to walk out the. I don't
Take
think
some
you
flex,
fully
push the
deflate
wire.
this.
when
No, I
you
did,
come
I
back
did.
out.
It's-
Pull the wire a little
Wire
bit.
back.
Yeah, so it doesn't
Get the
stuck
pigtail
anywhere. Good.
for the
Okay.
LV.
Good. Hold the sheath.
All right, show us the echo now.
Yes, this is the echo by commissioner view.
Let's walk this out.
The leaflets opening, closing nicely.
Sahil, can we walk this out?
Minimal central
Picture
MR,
ready.
most likely from the catheter. Minimal PVL. No significant. No
Do we need to inflate again? That was the only question.
Let's see here,
No?
gradient.
It's
Yeah,
for
that's
showing
the-
more.
the gradient here. Let's see.
Okay.
Let's see 3D.
Gilbert says
Let's
no.
get a
Okay,
picture.
we're coming out.
No PVL.
Like-
minimal,
No, it
minimal,
should not. It's
minimal,
quite
minimal.
Good,
oversized nicely.
Stamp?
Yes.
Okay. We are
doing
coming
some
out.
3D
No
here to show
inflation.
you.
Second inflation. Okay. Have the pigtail?
Yeah, pigtail is getting ready.
I think we've got a very good
Look
flare
at
of
that.
the
Beautiful.
valve.
You have
beautiful,
wire?
The ventricular
Beautiful
side.
3D image.
You have wire, right? You have wire, Sahil?
Yeah, yeah.
Yes? Okay.
Yes, yes.
No, I just make sure.
It's a live 3D of the valve. Minimal central MR, no PVL.
Yeah, we have a wire still.
Yeah,
so
no, most likely from the catheter. Leaflets
Perfect
open, close.
sizings.
Beautiful.
Yes.
Some glass image here.
Wow.
Let's take the glass away.
The 23 might have been less predictable here.
Yes, perfect size.
In this case.
yeah, because it's a shorter frame. You can see that,
it's a
right? So
smaller
now,
frame.
now you cannot have a gradient issue because it's nicely ventricular. This is perfect position for a 26 valve in this case. Because you don't want to be too much atrial, then you have a gradient issue when you oversize.
Beautiful. Want to do some gradients again?
This is some
Yes.
nice image here.
Okay, so we have a ventricular pigtail, we
Give
have a
us a
systemic
wire.
pigtail.
For the LV.
So we have some
get into
outflow
the
track gradient. You can
regular
measure
one.
it.
Yeah.
So we expect to have obtunded that V wave now.
Yes.
Well, we're in the ventricle still, the pigtail,
yeah.
so we have to bring it
Once you
back.
come out in the air.
Yeah, we can do a pullback. And we're going to put a pigtail from the arterial side to the ventricle, yes. And then we can pull back the transeptal
flush both
pigtail
of
from the
them.
LV
Yes.
to
And no purpose of doing any ventriculogram now, right?
No,
Because echo
no.
tells us
Well, but
everything.
also this patient, the
Exactly.
CT, there's no issue with LVOT, so we don't really need to. I mean, we can if we want to, just to show the position. I think that'll be a nice angiographic.
You want to show the angiogram?
Sure.
LV
Not
gram?
yet.
LV gram. We
No,
can
no,
do
no,
an
we're not
LV.
doing LV.
No, this
Okay,
is good.
good.
No, this is the LV gram. Yeah.
No, we're not doing LV. We
Okay.
are just-
Go to the
Okay.
hemodynamics now.
Yeah.
Did you flush?
I think the key
Can we
for the audience here is the
re-zero everything?
coaxiality of deployment. You can see that it tracks very nicely when you do an optimal transeptal. There's no, drama. There's no difficulty crossing. You do a nice balloon septostomy so you can make sure you don't get hung up in the septum with the device. And when you inflate, you go a slow inflation like what Dr. Keeney does, and then Sahil position, and then the third person, the wire, also try to maintain the optimal coaxiality. That's, I think, the key. It's a three-person job to get this kind of result.
Yep.
Otherwise, end up being cockeyed and rotated. So let's see.
Okay.
Good. Identical.
Okay, identical now. Yeah.
And obliterated the V
Obliterate,
waves.
Yeah.
So
No, we don't know yet. Let's
V
bring
waves,
the.
right.
your-
No, so far
LA.
looks good, right? You
Pull
can
back
see
on
the
the left
Nemo, right?
atrium.
I'm
Just
going
put
to
it in
pull
the-
back in the left atrium, right?
Yep.
Okay.
Now you need a wire, or you can just
No,
pull it
no,
out.
we
No,
can
this
just
is
come
okay.
out.
Okay.
Good.
Okay, so left atrium. So let
Left
us
RA
show the
now. Left
sorry.
atrium. Yeah.
Left atrium.
Not RA.
Yeah.
No gradient.
But how is the V wave still there?
Yeah, I think what happened is
No.
that it is a restrictive LA that
Yeah.
even though you have no MR, you still have the V wave because of the restriction of that LA. It was not a compliant, chronic,
Right.
fully dilated LA. That's
why?
my interesting observation
Give me
here
confidence.
on hemodynamics, suggesting that, as we know, the V wave is not necessarily equal to mitral regurgitation.
Confida.
Okay, echo wise, Stamp, put the echo there, please, and tell us what
Yeah.
we need to worry about or not worry about, or we are all good.
No, yeah, it's
We're going to put a confida back in the left atrium just to maintain access in case with the close AST. I don't think we need to.
there's
but
nothing
it's-
as you can see, some
What
central
happened to the
MR,
picture?
but no PVL, no significant PVL.
Huh?
The gradient I got
LA.
is 6.
No.
Uh,
Oh, there. Okay, good. I could not
so no
see.
PVL, as you can see.
Good.
Little bit central MR.
Okay.
Now, what
Stan,
about
can you show? Can you look at the ASD for us,
Yeah,
Dan?
yeah, I will
see.
show you CSD. Yeah, yeah,
Because we've done basically.
yeah, yeah. I can show you.
So we always maintain access before we remove this, and then we'll remove this with another wire, because obviously you don't want to pull this wire out by itself across the ASD. So
So as you can see, it's
multi-purpose.
The left to right shunt.
a measure for you.
Nothing, right? We can just
No,
take
wait,
the.
hold on. What are you doing?
No, we want to straighten that stiff wire before pulling out to the right atrium.
No, he's telling us, do we need to close or we can
I don't
leave
think
it,
we
right?
need. I don't think we need. To
Looks
go.
so small.
Help me give you.
Yeah.
You can just take the wire out actually.
No, not
No,
like
it doesn't
this is
work.
pre-curve though.
So
5 millimeters.
it doesn't look a big hole, so we can take the wire out. Or what do you think?
Doesn't look too big.
Huh?
No, not big. 5 by 1.2. 1.2 by 5.
Oh, then fine. Yeah.
Fine. Okay. All right. We're done.
You still don't want ventriculogram?
No,
I'm sure a
Okay,
lot of
okay,
people will like to see the
Okay,
ventriculogram.
we can do one.
no. I
Yeah,
mean,
let's do it.
you have an echo.
It's a good. Yeah, I know. It's
Can
echo
we-
is good. Let's confirm
set
the
it?
echo with the angio.
Everything I can do is.
This is the ventriculogram.
All right, guys, get ready with the
That's how much
ventriculogram.
pressure? Really?
12, 25, 1000.
This is how much pressure and volume you do for ventriculogram? 8
Yeah.
and 550.
No,
Yeah.
this doesn't
We're
work
going to
for
just do the
LV.
ventriculogram.
Doesn't work for LV.
Yeah, that's good.
Good.
1090.
We need to see the fluoro is there.
Okay, go back to the fluoro now. Echo,
Yeah.
we are done.
Yeah.
We are done with the echo. You can just show the fluoro.
Here you go.
Okay, freeze it.
Okay,
Nice.
and
Yeah.
then let me
Okay.
back out. Okay, that's it.
Good,
Ready?
good, good.
Yeah.
Go.
Beautiful.
Beauty.
Wow.
So you can see
Let
how
us
No
well
MR. It
positioned.
was all MR. Not even a single RVC is going.
Very good. Very
Wow.
nice. Very nice.
Wow, wow, wow.
Congratulations. Fantastic case.
Okay, so now what are the next steps? Sahil, you want to complete that? Because no ASD closure.
Yeah. So we're just going to
Then
close
just
the vein.
Close the vein and
Yeah,
that's it.
They have a figure of 8 in the vein with the
Figure of 8 in the vein. Okay,
Good. And
let's
then-
go to our presentation. We got about 10-15 minutes. Done in time, all. And these are the various features which we have in the consideration for the final valve deployment, which we have already spoken about, that you want to be a little less atrial, more ventricular, and the post-deployment echocardiographic assessments, which we have done. This particular case, which we have put it there, all fantastic in terms of no regurgitation, very little gradient, check hemodynamics, saturation, and criteria for ASD closure are the large predominantly left to right shunt with worsening RV dysfunction and largely predominantly right to left shunt and clinically significant hypoxemia. So none of that is here in this patient.
No, not with this device, but certainly with the other TMVR, like the Intrepid, they were done, right? It's a
Yeah.
much bigger device, 37 French. So those we have closed because it's
so
very big.
some of the devices which I'll show you, almost 40+%, or I mean 70, 80% you need to close it. And whatever cases we have done, we have closed in almost everyone.
Beautiful.
So what I'm going to do is next 10 minutes, that recent update in this TMVR field, which what is going on here. So clearly, lot of devices coming in. Some have been knocked out, some still continues. Two, I would say, kind of getting to the next level, and those are the Intrepid and the basically the Tendyne. So two of them. Others are still going on, Sapien M3 also, but many of them, as I said, they are being used in the mitral and many also being used in the tricuspid side. So these are the small series of cases, clinical experience with various valves. And so I want to just show one of the old data of the mitral trial. What they did basically is using the Sapien, both Sapien XT and Sapien 3 for either 90 patients total, one for the MAC, valve in ring and valve in valve. And basically they showed the data with the short term and the long term. As you can see, the height, the blue valve in valve in terms of success, orange is valve in ring and valve in MAC is green. So you can see valve in MAC is a trouble in every aspect. lower procedural success, and high death rate at 30 days, and more importantly, even at 1 year. They presented the data. Almost 62% of the patients have been, now aged because of the valve itself, comorbid condition, not necessarily because of the device itself, but very high mortality in a valve in MAC. So that is one of the issue, and best data are valve in valve, and second is valve in ring, as shown here. So question comes, what if these are the patients who are acute, particularly MAC patients? Is it related to the procedure, or is it related to their intrinsic disease? As you can see there, if you take the landmark of the 30 days, so basically valve in MAC, even beyond 30 days, has a 40+% mortality. So it seems to be these patients, because of their organic condition, their disease process, they have very high comorbid condition, nothing to do with the valve. So then question comes out that if you already have 60-70% 1 year mortality, why should you even replace it? Because what are you going to achieve by replacing when there is already a 70% mortality with this? Gilbert, you want to comment on that?
Yeah, I mean, and also anatomically, the ones that are favorable are very few, right? We screen out so many of them. So the ones that are left, we've seen them, they are pretty debilitated, pretty fragile. And the data speak for themselves. I think it's mostly palliative at this point right now.
Great. Okay, so now there is the whole debate is still going, and I think the answer is not there. That should you put a valve like this particular case? This is a different, because it's already on warfarin. But question is, if you're not on warfarin, do you need to put an anticoagulation? And we actually favor anticoagulation, although we are not 100% on that at present.
Yeah.
So the data definitely are that you should be on anticoagulation when you're using the TMVR for valve in valve. Now they actually have come up with a further in this valve in valve group. And overall, as you can see, in terms of the NYHA class, the 6-minute walk test, Kaplan-Meier survival, very, very good. Median STS risk is 9.4, with mortality is very small in selected patients. So valve in valve with using the SAPIEN valve is a way to go in our cases. So these are the 1 year outcome so key remains is the particular issue which we have already spoken, and that is basically the top one, valve in MAC. And as you can see there, success rate is lower in various registries, very high mortality. So that group continues to be a trouble, and that's where many of the studies are happening at present. And now there is a trial called Mitral 2, pivotal trial of the SAPIEN 3 or SAPIEN 3 Ultra in patients with symptomatic severe calcific mitral valve disease with severe mitral annular calcification who are not candidate for the standard valve surgery. There they are incorporating imaging by 3D, 4D CT reconstruction and really have a full ring and enabling that which patient should get the SAPIEN valve, TMVR in those MAC. So I think this field is still very and of course we have Intrepid. There also those patients are not randomized. MAC patients all getting Apollo. But where are we on in terms of Intrepid Apollo for the MAC?
Yeah, no, they've been enrolling patients, but these patients have bigger ventricle, bigger anatomy, right? Not like the SAPIEN. So again, it's screening issues. So same as Tandem as well. So.
The issue remains continue. So there is actually a very nice for management of patients with severe MAC, nice review article this year. Really goes through all these aspects of using that echocardiography, CT, with a multiplanar and to really see 3D and 4D reconstruction and try to see where your valve will be to avoid embolization, neo-LVOT. So all those things are being considered before you decide for the MAC. And I think that is one of the factors. And nowadays we can always kind of virtual reconstruction and of course follow up these patients that have been shown. So this is actually a nice simulation that how the valve will be, and hopefully we'll do our case, get a CT, we'll have some of those nice pictures. Now, also the MAC is a trouble for surgeons. So what do you want to comment, Gilbert, on that?
It's really the placement of the sutures. Calcium is hard, so the needles will not drive through. And if you debride, we used to try to surgeons debride this calcium, take it all out, reconstruction, but there's also risk of LVOT, so AV groove rupture. So that has been a challenge. So here we typically can do a palliative repair, not just actually replace the valve, but if you replace, we also done the hybrid approach, where actually if it's really a lot of calcium that is not safe to remove or even dry suture, we put a sapling free directly.
Right.
The beauty of the hybrid approach, you can actually suture some of that and put a felt there to reduce paravalvular leak and also make it more secure.
And that is where they're doing with the transatrial.
That's right.
Using the sapien, so use the suture and place from the left atrial side. And we have done few cases here.
Yes.
With this, so this hybrid surgical approach, as Gilbert pointed out, it may be in some cases is better, but it's this field is still very nascent in the sense that a lot of work being done for valve in MEC and what you should be doing. And so Tendyne also has been used. Some of the cases, mitral trial already I've spoken about, and we have the data from TMVR in MEC global registry and from the STS registry. So overall, so as you can see, very high incidence. The majority are done with a transapical, but now getting a transseptal. And the mortality is still remain about 50+% in these cases. So they have actually proposed a nice algorithm that if patient is a not high probability surgical risk and favorable anatomy, then it's a good case for the TMVR. I mean, if there is no, then you think about surgical repair or mitral valve replacement. But if it's a high the surgical risk, then in some cases palliative. Not necessarily knowing that it's a 70% mortality at 1 year, what are we going to achieve by replacing the valve? So it has to be favorable anatomy for TMVR with acceptable risk of complication, and more important, the patient's lifespan. The patient FEV1 of 300, we know that CC is not going to survive more than 6 or 9 months, and so this is basically a nice algorithm which these authors have put it for management of this MEC in these patients. So now the question comes is that the newer devices which keep coming with the various data which I have briefly shown, 2 trials, Summit and Apollo is still ongoing. Summit actually have been done with the Intrepid, which actually had led to, I showed that data earlier, very good in selected cases, but transapical and long functional capacity, quality of life, decrease in regurgitation is quite good. And that led to approval of the device almost 2 years ago in Europe. It is still not available, not approved yet. Where are we in US?
They're still going on a trial, the Summit, I think.
Summit trial is still ongoing, so we're still not there yet. The second, and of course, they also have used in the MEC, presented the data in the Euro intervention, that in cases, again, 75% success rate, although technical success rate is quite high, but 1 year mortality is about the same 45-50% as we talked. Apollo, as we have spoken about, that we are going on trial, slow enrollment, but this group of patients, what really exciting is do this with the TMVR using Intrepid valve with the transseptal approach. And this is what the early feasibility study, and there's just same kind of a little different design of the mitral clip, and 30-day data were presented and published showing excellent results. Look at that, 100% reduction, no mitral regurgitation in all this small number of cases, but 14, 0 mortality, 0 stroke, 0 reintervention, 0 pacemaker, and 30-day 0 mitral regurgitation with excellent improvement in functional class. We actually have done 6 cases now.
Yeah, including one in MAC actually.
Yeah, and one in MAC, and doing quite well. So this, I think, this whole field of TMVR will explode once we get the transseptal, because clearly we learned that even with the tower, the transapical was always a trouble. So once you take away from the trouble, because these patients are very old, comorbid condition, transapical really has higher problem. You make it a transseptal, this will be the way to go with these various valves. And only this problem was 73% require AST closure, and 40% was the vascular complication. Now, we did not have any by our technique of venous cut down. What are you doing?
Yeah, no, so this is an early experience. I think they figured some of the stuff that the learning curve now. We have zero vascular complication because we always do very meticulous closure. And you have to close AST, we learn now we close from the left side, not from the same side that you do the cut down.
Okay.
That's the key.
And it's a venous now cut down we are using
Yeah,
at
but
present.
once the next generation coming next year, it should be percutaneous.
So venous, that's very important. Now there's another valve. As I said, keep coming. Another valve for the TMVR has been approved with a Cephea TMVR system. And key question comes now, knowing that clip, and now we actually have Pascal from Edward, and both are available. Which one would you use? And they have put it together. Basically, if you're nice anatomy, not big coaptation gap, not calcified, the repair will be okay. But many of these cases, which we are doing, of course, valve degeneration, but otherwise without the valve in valve, only cases are basically we're still calcified, but has to be both stenosis regurgitation and careful selection of these patients will be a key, because most of the new trials, they have an arm of TMVR versus TR. So there's all these new devices will be basically compared against. So just to sum up, the TMVR devices are increasing and their use is evolving in carefully planned clinical research trials. Initial data of TMVR devices are satisfactory with high procedural success with reasonably low complications. Only subgroup of TMVR in MAC remains challenging with high short and long-term mortality. Sapien percutaneous valve is the most commonly device used for high surgical risk mitral valve disease patients at this time. Newer devices for TMVR have great promise, and transeptal TMVR is poised to change this field with excellent device performance, safety with increasing focus on reducing vascular complication. As we have spoken, vascular cut down, venous cut down, or maybe the device size will go down. So mitral valve degeneration due to MAC continues to be challenging, and newer devices are focusing in the treatment of this very high risk challenging subset. And advanced imaging modality 3DT, 4D, and virtual CT are vital in careful patient selection and proper procedural planning. So our questions, following statements are true regarding the short and long term results observed in the mitral trial, except valve in valve has the best outcome, valve in ring has the intermediate outcome, valve in MAC has the poorest outcome, and self-expanding valve has good outcome and can be used in these cases. As you know, the answer is D is wrong. There will be no self-expanding valve for the mitral position. They all are balloon expandable. Following parameters will favor TMVR over TR, except mixed stenosis and regurgitation, large coaptation width and gap, non-calcific pliable leaflets, mitral valve cleft or perforation. Clearly the answer will be that C. Non-calcific pliable leaflet basically is a good for TR, others are good for TMVR. The third question, following are the results of the transeptal EFS TMVR of 14 patients using Intrepid valve, except 0% vascular complication, 0% mortality at 30 days, 0% MR at 30 days, 0% permanent pacemaker at 30 days. And answer is A, because we know vascular complication was about 40% in this initial series. With that note, Pedro, we conclude our today's presentation, and hopefully it will be it's a very educational step-by-step approach which we showed. TMVR we have done almost after 3 years now, and the steps which we have spoken and Dr. Keeney has mentioned, everything is there on the slide set. So anybody, it will be a resource for operators to go back and look into it, because last time was in January of 2018 in terms of the description of the procedure itself.
Well, this is an unbelievable case. Thank you so much for the Cath Lab members for this exciting step-by-step, absolutely pristine, beautiful case. For the audience, remember this case and all the other cases will be available this afternoon in ccclivecases.org. Remember, we'll do our heart structural valve cases on the second Tuesday every 2 months. So our next one will be Tuesday, January 10 at 9 in the morning. Thank you so much.
And we have the Valve Symposium on December 8th. Thursday, December 8th, we have the New York Transcatheter Valve Symposium, and that is a 1 day. We'll plan to do about 6 cases plus structural cases on that day with the key topics and the discussion on many aspects of the emerging field of structural intervention. Who should get the clip, who should go for surgery in various kinds of mitral regurgitation, and of course high risk tower anatomy. So we'll try to show all those cases, and more important now, the new disease is coming up, the tower degeneration. So what do you do with it? TAV in TAV, all those type of cases will be highlighted on our December 8th symposium. All right, thank you very much.
Thank you.